günaydın. Sorry, I should talk in English because my Turkish is not very good. First of all, I want to say my real appreciation to Professor Tufan Turka and all professors for this amazing and well-organized Congress, and I am very happy. I spent a few days here, I learned a lot, and thank you. So I want to talk about chronic pelvic pain and voiding and sexual dysfunction. All we are urologists. We know about this tragedy and this real suffering patients. Chronic pelvic pain is not for old age patients. This is for young age patients. And these kinds of patients, they are coming to our clinic or our office with a plastic bag full of medicine, a lot of imaging, and they are really suffering from pain, and they don't have a real normal life. Chronic pelvic pain, all doctors, professors before me, they explained very beautifully about that, but I want to emphasize about chronic pelvic pain is not a really pain, and when we are asking patients, they are referring and showing the pain place. They cannot show with a finger or a place, just they are referring the whole pelvic floor. And chronic pelvic pain is not a short disease. At least they have 3 or 6 month previous history. They describe pain sharp, intermittent, some heaviness in the pelvic floor, and sometimes it is not pain, is a kind of burning or heaviness in the pelvic floor. And many of them, they have this kind of pain, not always. This pain triggers with intercourse, with sexual act, and also with urination or bowel movement. About the causes of CPP and chronic pelvic pain, all Dr. Omer, and other doctors, they say it, so I don't want to waste your time. But we should aware about this disease. Chronic pelvic pain is not only one disease. It comes and it is common with another disease like IBS, bowel syndrome, irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, chronic pain disorder, endometriosis, PID, and prostatitis. All of us, we are urologists, we know prostatitis is a disaster. The patient that they have chronic prostatitis, they are suffering from voiding dysfunction, pain, sexual dysfunction. So the chronic pelvic pain is not only one disease. We have many diseases together. I want to refer about pain. What is really the meaning of pain? The pain modulated by cognitive factors, and it triggers with past or present emotional experience. So if we have one patient like a young age lady, doctor said about 33 years old, comes to our clinic, even bad experience in the past triggers her pain. So we should know about this disease also. Compulsive obsessive is very common in Iran. I don't know in Turkey you have or not, but many ladies, they are suffering from compulsive obsessive disease. And body dysmorphic. What is voiding dysfunction role in CPP, or which kinds of voiding dysfunction we have in CPP? In chronic pelvic pain, because it is referred to muscles, if we have hypotonous pelvic floor muscle or hypertonic pelvic floor muscles, it makes some difference for the voiding dysfunction. The patients that they have hypotonous pelvic floor or loose pelvic floor muscles, they have leakage of urine, they are always wet, they have leakage of urine and some heaviness, rectocell, cystocell, or residual urine, and mainly UTI. But for hypertone or tight pelvic floor, they have difficult passing of urine, they have dysuria, burning in vagina or meatus, constipation, and also vaginismus. So as a lady doctor, I can touch the lady's word that how much is difficult for ladies that they have pain, they are active in the society, they have office, or they are lawyer, or any blah, blah, and between the meeting, they should run to the bathroom because of voiding dysfunction. Really, it is disaster. About bacterial prostatitis and chronic prostatitis that makes voiding dysfunction, I don't want to talk because it is very clear for all of us, we are urologists. I want to emphasize about sexual dysfunction in chronic pelvic pain because this is really a neglected area. We have three aspects as a human sexuality. We have three aspects of sexual function. Sexual function related to self-concept, self-esteem, having good body image about ourselves, and sexual relationship and satisfaction. And pain affects all aspects of these sexual functions. Affect to the self-concept, affect to self-esteem, and affect also to relationship. Because of the pain, they cannot move freely, they cannot open their legs, they have limit position, and they cannot have satisfaction after sex because of pain. Sexual dysfunction in female is referred to vestibulodynia, vulvodynia, dyspareunia, and vaginismus. Why? Because all these affect to the muscles, and muscle, if we have chronic pelvic pain, muscle affected and affect to the another vestibular valve. Because pelvic floor muscle, especially levator ani, bulbocavernous, ischiocavernous, they have main role for sexual process in the ladies. Levator ani is responsible for vaginal introitus, and at the intercourse time, levator ani responsible for opening the vagina and satisfaction, and bulbocavernous and ischiocavernous responsible for orgasm phase. So if we have any problem in pelvic floor muscles, all these factors affect to the sexual function. Before, pain etiologic factors in the past completely was different. It's related to preanal laceration, episiotomy, forceps surgery, and psychological factors. And I want to just say a small about the prevalence, that it is very common in young age. So chronic pelvic pain, we don't have chronic pelvic pain, mainly we don't have after 50 years old. All patients, they are young and sexual active, 14 to 34% in younger women and 6.5% in elderly. So these group, they are young patients. And imagine one lady, young lady in sexual active life period, they have pain at the sex time or introital or deeper pain. If they have at the beginning of vaginal introital pain, it's related to vulva, vestibule, hymen, pelvic muscles, and deeper pain related to organ and like PID or endometriosis or another factors that affected to deep muscles. Primary vestibulodynia and secondary. Primary vestibulodynia refers to patients that they don't tolerate anything, even doing physical exam, finger, tampon, but secondary, they had before comfortable sex, now they cannot tolerate. So we should be aware about, is this patient has vestibulodynia primary or secondary? Because of complicated three-dimensional organic system and clitoris, really is very complicated for description of these kind of pain, because clitoral hood, clitoral glands, urethral opening, and also all G-spot, arm of clitoris, bulb of clitoris is very important. Clitoris is a three-dimensional, it has a three-dimensional anatomy. So if we should know about vestibule and vulva, if the patient really has pain in the sex time, in pain in the clitoris or vestibule, this is not only one point. This is really complicated because of this anatomy. Different systems and different nerves affected to vulvovaginal pain. Inferior hypogastric plexus, caudal, sympathetic, pudendal nerve, and all afferent and sensory afferent affected from spine to urethra, vaginal mucosa, vestibule, vulva, and till pelvic floor. We have four kinds of dyspareunia. Dyspareunia related, type 1 related to tissue problem, tissue trauma, like inflammation, like herpes, like some lichen sclerosis, or some tissue problem. And it going to the dyspareunia type 2, like post-herpes pain or previous history of infection, and type 3 related to muscles, and type 4 related to nerves. So that's why we should know about tissue abnormalities, and we should do physical exam based our diagnosis. We should know about candida, herpes, bacterial vaginitis, and also the previous history of radiation is very important. Mainly, I think the most common dyspareunia is type 3 and type 4 because of pelvic floor. This is a very beautiful article I found, that they checked histologic finding in vestibulum in women with vestibulodynia, comparing with control group, and they realized that nerve fiber proliferation is very higher in vestibulodynia patients than normal group. It means that the patients, they have vestibulodynia, their nerves, they are more sensitive. Also, hormones have some role, like estrogen or reduction of testosterone. And recently, there are many literatures talks about low dose of OC3. What is the difference between dyspareunia and vaginismus? You know better than me, many vaginismus clinic and many gynecologists now in Turkey, they open the vaginismus clinic. It means vaginismus is very common, and they are only working in vaginismus and making money. So the difference is, if patient have persistent or recurrent pain with vaginal entry or with finger or physical exam or penile pain, it means dyspareunia. But vaginismus is persistent difficulty to allow vaginal entry. The patient, they don't allow to do physical exam. We want to do physical exam. They didn't open the leg. So it is more, vaginismus is more psychologic and more emotional patient than dyspareunia. Really, vaginismus is mysterious disease, and that's why maybe it's making money from vaginismus is now is starting every day and going, opening a new clinic for vaginismus. And this is because very limited evidence for the reason. Education is very important, reduction of fear and anxiety, asking about the previous abuse, or like doctor said, about child age marriage or young age marriage. And the treatment should be about desensitization with finger dilatator. Many dilatator came to market for vaginismus, and also CBT. CBT therapy is very common now. Between vaginismus and dyspareunia, sometimes we have overlapping, and we should know about that. And sexual pain really is not one disease. Sexual pain needs at least 1 hour consultation with patients in ladies. Ladies completely, they are complicated personality enough. And for sexual pain, we should have consultation more than 1 hour. The psychopathologies, anxiety, depression, phobic anxiety, obsessive compulsive, social anxiety, taboos that doctor said, marital problems, all affect the chronic pelvic pain. For vulvodynia, we have some psychological distress, for some pain amplification, also for physical anatomical factors. Patients that they are suffering from vulvodynia, and they are mainly, they have they are depressed, they are using antidepressant medicine, anti-anxiety medicine, and they have peripheral sensitization of pain, and also problem in like PID or pelvic floor muscles or previous trauma. So what is the diagnostic approach if one lady comes to our clinic with pain? the first step is a good medical history. Good medical history, not only physical exam. We should ask about taboos, parents, husband, previous partner, sex life, sex type of husband, because it's related to the character. And pain history is very important. Is it lifelong or secondary or primary? And clinical investigation is pelvic exam, Q-tip test, ultrasound, checking the residual urine, checking the urinary problem. And also past negative sexual experience. Of course, in our culture, they have taboo and they don't say, but we should be, very smart, and we should find about the past history. For vaginismus, I learned from Turkish vaginismus clinic that they are doing lidocaine plus methylprednisolone, betamethasone plus lidocaine. They are injecting to vagina, or they are doing in surgery. Me, as a urologist, as somebody working more than 10 years in sexual dysfunction for ladies, I'm against of doing surgery for vaginismus, but they are doing. And I think that one of the high incidence of doing surgery in Istanbul, in some clinic, they are doing perineoplasty, modified vestibulectomy, or sometimes vulvar vestibulectomy for treatment of vaginismus. I don't know the result, but okay, so sexual pain disorder for ladies, we should know about this is the vestibular, superficial or deep, and based the history, based the physical exam, we should treat is if it is superficial, like something for introital or vestibulitis or vestibulodynia, or it is deep, if they have deep pain in the intercourse. It refers to the pelvic floor muscles, to the PID, endometriosis, and other problems, or sometimes the high degree of cystocele and rectocele. So what is the sexual dysfunction relation with CPP, or chronic pelvic pain, in male groups? The main groups of chronic pelvic pain and sexual disorder in male, they are is chronic prostatitis or bacterial prostatitis. You know better than me. Chronic prostatitis is a disaster. The patient, they really suffering from pain, from voiding problem. He has pain at the long time sitting position. And I don't want to talk about prostatitis because it is clear for all of us what is the voiding dysfunction, what is the voiding symptoms, and what is the sexual symptoms. Because if somebody has chronic prostatitis, he cannot satisfy with sex. He cannot have the normal orgasm. Of course, I want to talk about delayed ejaculation, painful ejaculation, and post-ejaculation illness. These are new topics that you can find in articles related to chronic pelvic pain. Some patients, I had one patient, because in Tehran I am visiting also male and female patients. I had one patient that he had pain, chronic pelvic pain, and he didn't have ejaculation. After 30-40 minutes doing intercourse, he had delayed ejaculation, and he was suffering a lot. So for these kind of patients, for delayed ejaculation or painful ejaculation, we should know about the physiology of ejaculation. What is the ejaculation? This is the forceful expulsion of sperm from the urethral meatus. So it means many muscles, they have act and function in ejaculation. So if we have problem in the pelvic floor muscles, they have a problem in ejaculation. Secretion of seminal fluids from accessory sex gland is the responsible nerves is parasympathetic. Contraction of seminal tract from the epididyme to the prostate, the responsible nerves sympathetic way. Transport of seminal fluid to posterior urethra, again sympathetic. And closure of bladder neck is sympathetic. So if we have parasympathetic or sympathetic problem, the patient's ejaculation will have problem. And bladder neck closure, bulbospongious muscle contraction, ischio-cavernous muscle contraction, also related to somatic nerves, and rhythmic regular contraction of the striated perineal muscle that makes the ejaculation nerves responsible for this rhythmic regular contraction is hypogastric and pudendal. So some patient, because I'm doing neurourology cases, for some neurogenic bladder cases, for some caudal problem with patients, they are suffering with wheelchair. They are suffering from neurogenic and they are on the wheelchair. They don't have ejaculation because the hypogastric and pudendal nerve has problem. Delayed ejaculation is psychogenic or side effect of pharmacological treatment. We should aware about the side effect of antidepressant medicine and the pharmacological side effect, and also sometimes delayed ejaculation is the first sign of multiple sclerosis. Antidepressant like SSRIs, tricyclic tramadol, I don't know opium is available in Turkey or not, but in Iran, some people, they are using opium, and they have delayed ejaculation. Some men, they're using opium for treatment of premature ejaculation, and they got delayed ejaculation, and also neuroleptics. Another disease with chronic pelvic pain and sexual dysfunction in male is painful ejaculation. Painful ejaculation mainly is in acute bacterial prostatitis or chronic prostatitis, and they have really severe pain, and they don't want to do sex because of this bad pain. And alcohol syndrome, this is one neurologic, and retrograde ejaculation, only one slide, but we should know about the retrograde ejaculation after prostate surgery, and post-orgasmic illness syndrome. I had only one patient in my practice more than 10 years, and I was thinking he's really a psychopath person. And after I realized that he had post-orgasmic illness syndrome. This is nasal congestion, itching eyes, flu-like syndrome, muscle tension, and extreme fatigue and foggy feeling after ejaculation. It takes time like minutes, hours, or seconds. And treatment is some autologous injection of semen to them. And we should be aware that chronic pelvic pain is not one disease. We should treat holistically, as holistic approach. And this is one poem from Mevlana, 5 persons going in a dark room and touching elephant. Unfortunately, I couldn't find the Turkish poem, and I know about Farsi poem, that the 5 persons in darkness touching the elephant, one touching the nose of elephant, he says this is a snake. Another one touching the leg of elephant, he says this is a column of building. So if we go one part of chronic pelvic pain, like we are touching in darkness, one part of elephant, we should be aware about that, and we should do multidisciplinary treatment, and thank you.